last case, and then I will go to candidate 5. So be ready, candidate 5. Just point out candidate 4, this calcification. Where is it? Are you with us, candidate 4? I have to unmute her. Okay. So now I have unmuted.
Yes, sir. So that's the calcification is seen in the pancreatic region. That's the pancreatic calcification.
Excellent. Excellent. That's fine. Because of time factor, I'll carry on. So if you see this calcification, classical and calcification which goes over the spine, classical for pancreatic calcification. And pancreatic calcification has got a differential diagnosis. And chronic pancreatitis, vascular calcification, pseudocyte calcification within a tumor. This is very important for you to remember. And I urge you to read the details of 8.32. I don't have time to go through it because it can save you in the exam. You know, for example, adenocarcinoma of the pancreas, which is the most common pancreatic tumor, unusual to have calcification unless there is chronic pancreatitis. So that's a nightmare scenario where a chronic, please remember that pancreatic adenocarcinoma is prone to develop in chronic pancreatitis, but neuroendocrine tumor usually will show calcification. So this is a point to remember. Many, things you have to remember. Many of these things you have to remember because it can also become a sort of a long case. So read this differential with great details, should I say. Candidate 5, raise your hand, please. I cannot see candidate 5.
It says candidate.
Candidate 5.
Yeah.
Okay. Yeah. So now I have got you. Are you with me?
Yes. Can you hear me?
Okay, just, we can hear you. And please, it's quick because we are going to crack on. Where is this calcification? This is just to develop your eyes.
Intraperitoneal.
You see, it's very well defined. It is within a viscera. This is what we call a visceral type of calcification.
So then looks like within the gut.
Okay, something which can be so large among the viscera.
Large gut.
Anything else? This patient is quite, clinically speaking, quite good.
Where else could it be?
Think gynae.
Okay, so it can be pelvic, like fibroids, calcified fibroids.
Yeah. So these are, please remember that fibroids, the uterus can go all the way up to the diaphragm and they can be huge and they can calcify. So this is the visceral type of calcification. And what I'm showing you is quickly just, pattern recognition. So nothing more than that. Is there any organomegaly?
Yes, looks like on the right side, upper abdomen, so most likely liver.
Excellent. So these kinds of cases can come in the exam, and then from here, once you pick it up, the ultrasound might be shown to you or something else might be shown to you. Where do you think is this calcification?
Okay, so this can be either within the liver.
Excellent. So this was within the liver, which is a very enlarged liver. And this was actually metastasis post-radiotherapy. So they have calcified there. Metastasis, you see this metastasis? A calcification within a mass. So it can also happen. Where is this calcification?
Okay, so this is in the left upper quadrant. So I can think of a spleen, calcification within the spleen, or I can think of if a large mass within the adrenal, but it's a bit high and more laterally. And I can think of something within the pancreas.
Okay. Same case.
Okay, so this is a barium contrast meal, which is opacifying the stomach, which appears to be a narrow lumen, and there is cross thickening. This is like a typical appearance for linitis plastica.
So where is that calcification?
So that calcification would be within the stomach. So it.
Yeah, actually you can see it. You see from here to here is that thickening. Now you can see. If you go back, this is that calcification, and look at the shape of that calcification. It goes with the stomach. Very unusual case. I'm not expecting that you will pick it up, but just to develop your eyes, that sometimes these kinds of things happen. And the basic thing is that this is linitis plastica, and we will cover it in the next session in detail, where there is loss of distensibility, and you can see that there is mural thickening also. This calcification, what do you think?
Adrenal or kidney?
Adrenal, very good. So this is adrenal calcification. Adrenal calcification is again an exam calcification, because then the differential diagnosis will be asked. And this is the differential diagnosis, which you can cover in 9.3. Where is this calcification?
So it's in the left upper quadrant as well. So pancreas, a pseudocyst, calcified pseudocyst, or.
Excellent.
Okay.
So this was a pancreatic pseudocyst, and this one is sort of calcified. Where is this calcification?
In the region of kidney, left kidney.
Look at the shape.
Quite difficult to actually.
Do you see that how is the shape here? There is something here, snake, serpentine, tortuous. What comes?
Could be vascular calcification.
Yeah. So in this region, what kind of vascular calcification? Actually, you will see it very commonly in old age patients.
Splenic artery?
Yes. So this is, please remember that splenic artery is very tortuous, and it is classical like this, that where you will see this calcification as well as its tortuosity. What is this?
So this could be aneurysmal aorta calcified.
Yes, and this is an aortic calcification of aortic aneurysm. What's happening?
This most likely is calcified gallbladder.
What do you call this thing?
Porcelain gallbladder.
What do you advise? What will you advise?
This is worrisome because it mostly develops gallbladder carcinoma. So it would be urgent to do a CT scan.
Okay, that's fine. And even you see on the CT scan, you will see the same thing. You might see a tumor, might not see a tumor. Even if you don't see a tumor, what are you going to advise?
So this has to be like removed there and then. So cholecystectomy.
Cholecystectomy, you have to advise a cholecystectomy. If you see latest literature, the original literature was quite emphatic about development of carcinomas. Some of the latest studies, they are not all that supportive. Having said that, the concept stays. The percentage of patients who develop carcinoma has reduced in latest literature. Having said that, the answer is in the exam and in your clinical practice, you will advise a elective cholecystectomy. This is your last case, and then number 6 should be ready. If you can tackle it as a viva film, and I'm listening to your description, please. Over to you.
Okay, so this is a plain X-ray abdomen frontal view of an adult patient. I can see multiple dilated bowel loops predominantly in the center of the abdomen. In the pelvis parts, one of the bowel loops is like I can see the wall in and outside as well. So I'm suspecting it to be a regular sign and pneumoperitoneum in this one.
Okay. So anywhere else, do you see any signs of what we call pneumoperitoneum? Your diagnosis is correct.
Okay, I can, other than the regular sign, within the hepatorenal angle, Morrison's pouch,
Excellent.
there is a triangular cap sign.
Okay, well done. You can mute yourself. I'll take over, and candidate 6 should be ready after this fill. Now, if you see here, in your exam, pneumoperitoneum will always be shown on a supine abdominal film. In an FRCR level, nobody is going to show you a chest X-ray for that. So regular sign is one of them, where you see outer as well as inner surface of the small bowel. I warn you, when small bowel loops are dilated and distended, and they are projected over top of each other, at times we get what we call a pseudo-regular sign. So you might confuse it. Now, so this is regular sign. Then within the, now we are going into the world. What are the signs of pneumoperitoneum on a plain film? And you can see at times gas accumulated. For example, here it is, subhepatic region. You can see this gas here. It's known, and there is gas here also. So these things should be in your mind. Now this is free gas under the liver, and this is an exam sign where falciform ligament is outlined by the gas. I'm sure all of you know this, and you have to point it out to the examiner that this is what it is. Okay, candidate 6, can you please raise your hand? So I have clicked you, and I hope it's worked for you. Are you with us, candidate 6?
Yeah.
Okay. This is my favorite film. Over to you.
Okay. So it's a frontal chest radiograph as well as a abdominal radiograph, which is demonstrating there's no free air under the diaphragm on this abdo X-ray AP racked. However, I can see there's a dilated lunar bulbs in the abdomen. This in the center of the abdomen, there's a round gas shadow.
You have picked up this shadow. Well done.
And can't see any. There probably is a regular sign, a hint of regular sign adjacent to this shadow. Not convincing though.
So,
this film is not. I mean, ideal, but I would have liked to see the lateral walls of the abdomen as well as the stomach to see whether there's a gas under the liver or falciform ligament is marked. Also, I can see the probably gas.
Okay, I'll stop you here. Now, basic thinking on a plain abdomen film, as I told you, when you pick up any gas, you have to ask yourself, is it in the lumen? Is it outside the lumen? Or is it in the wall? You have picked up this rounded shadow. Now, if you see here, this is the transverse colon, right? Mm-hmm. What is this?
That's stomach.
That's stomach. So is it in or outside?
That's in the left.
Stomach?
That's outside, extraluminal.
So what is the conclusion?
So it's a retroperitoneal gas in the lesser sac, most likely.
In the lesser sac, or okay. So this is the CT of the same case, and do you see any pneumoperitoneum?
There is pneumoperitoneum.
Look at this one.
Yeah, there is pneumoperitoneum, quite large amount
Is it cross pneumoperitoneum?
Yeah.
Right?
Mm-hmm.
Where is it sitting? It is sitting here in the center, and this is what we call the football sign or the cupola sign. Here, what happens is that there is large amount of free air, but it sits in the center part. And the beauty of this film, and this is a classical example, that this gas, you can see that it is away from the stomach. It is not, and this is a large amount of gas. So in the central portion. So this is football sign or the cupola sign. This is a cupola. Okay, over to you. Where is this gas? What's happening?
In this plain abdomen X-ray, I can see gas outlining the psoas muscle as well, and kidneys.
Mm-hmm.
So kidney is quite delineated. So it's a retroperitoneal gas.
Yeah.
Yeah. So patient has a surgical procedure. So I'm just wondering what kind of so retroperitoneal gas could be because the retroperitoneal structures hollow viscous which are ascending.
Why do you say so? My question is more basic. Mm-hmm. Why do you say that there is retroperitoneal gas? So the learning points are, where do you see retroperitoneal gas?
Outlining the psoas, in the outlining the kidneys.
Excellent.
And it should be in the deep pelvis, outlining the rectum as a part of the rectum, which is retroperitoneal.
Outline will very difficult to see.
Yeah,
that.
Lesser sac you can see in lesser, but obviously on plain film it's difficult to pick up.
Is lesser sac by definition retroperitoneum? You remember lesser sac has got a connection with the peritoneal cavity, so that's a peritoneal.
Okay. Yeah.
If you see here, let me take over. Now, this is a very good film to develop your eyes on where can retroperitoneum be. So, of course, it is outlining the kidney, outlining the psoas, right? But other things which you have to remember is, this is the hemidiaphragm. The posterior portion, posteromedial portion of the diaphragm is touching the retroperitoneum. Another sign which is now if you in your exam you pick it up as a retroperitoneal gas, of course you are passed, but you want to get more and more marks, and the more fine touch is that you have to pick up the finding. Another beautiful sign is this one, which we call large bowel regular sign. If you go back to your anatomy, remember that the ascending colon as portion of the ascending colon and portion of the descending colon is in the retroperitoneum, right? And when that portion is outlined by gas, you see this is portion of the descending colon and there is a large bowel regular sign. So this is another sign. If you pick it up, as an examiner, I'll give you half a mark more, and you have to take it so that you can compensate for any other fill. So causes of pneumoretroperitoneum, you can also add it. I think this is from Radiopedia, if I'm not wrong. Now, another point, there are two specific questions I want to ask. This is a case of, again, pneumoretroperitoneum. You can see, look at this diaphragm, the posteromedial portion that is outlined. What is this in the spine? What's happening here? So there's a bit of story, what is the story here?
So patient has got degenerative disc disease, and then there's a spinal fusion.
Not at all interested in the fusion, etc. What is this high density? You see this high density?
Yeah.
And
yes.
This high density is actually outlining maybe, maybe nerve roots here also.
calcification of anti.
So hint story, and the story is that this is something which was done in 1980s. Okay, so in that era, we used to do myelograms with a contrast agent, which was known as myodil, and it could stay there forever like this, and there was a lot of toxicity, etc. Please remember that these patients are still around; they are still alive. And if you see it, it's a got of Aunt Minnie type of an appearance. Nothing else can give you this kind of appearance. Even the nerve root is out. Rapid reporting. Yes. Hear me.
Yeah, I can hear now. Sorry, there was a lag. Sorry, yeah, connection lag.
Okay. Now, rapid reporting, normal or abnormal?
Abnormal. There's a gas underneath the right hemidiaphragm. So it's peritoneum.
And do you see anything in the chest? Gas anywhere?
Just trying to look for the pneumomediastinum.
Excellent. Your thinking is absolutely correct, but where is it?
On the right side. In fact, going all the way on the mediastinum. Yeah, there.
Not here. Actually, maybe it's not projecting for you very clearly, but actually this is where it is. You can see this pneumomediastinum. The learning point here is just the same thing. If you see, this is the posteromedial portion of the hemidiaphragm. When it is outlined by gas, and when this is outlined by the gas, anatomy is that this can be retroperitoneal gas. If you see here, this patient has got outline of the psoas like this. Now, I will show you a case. I think, sorry, I've shared the. So I'm showing you this case just to develop your concepts and your eyes on the concept of pneumomediastinum and retroperitoneum, etc. Now, if you see here, number 6, can you see a CT scan?
Yeah, I can see.
Okay, so I'll just give you what I wanted to show here is that if you see here, you have got pneumomediastinum here. Now, what is happening? That pneumomediastinum. Now, do you see how it is going just along the crust of the diaphragm?
Yeah.
And now it is going into the peritoneal, the retroperitoneum. It is outlining all of these retroperitoneal structures. So the kidney and the psoas, and this is what you see in the plain film. Another thing, another concept which I wanted to show you. You remember that I told you that portion of the ascending and portion of the descending colon is in the retroperitoneum. So here is the proof that portion of this ascending colon is outlined by the gas here. So gas bubbles are going, and similarly, if there were gas here, it would have outlined. So let's see the coronal of this one. And now, this is, of course, the colon, ascending colon, gas here. And then this was the leveling point under the diaphragm, And another thing is that gas can go from the mediastinum into the retroperitoneum, also the peritoneal cavity, and vice versa. Do you see how it is going superiorly? So through this hiatus, and now it is going into the mediastinum. So I'm just showing you to develop your concepts that what exactly can happen. Okay, now